Shortness of breath is one of the most anxiety-provoking complaints for patients and for students. Because when someone says, "I can't breathe," your differential instantly explodes. You're thinking pulmonary embolism, pneumonia, asthma, heart failure. And if you don't structure your thinking early, you either freeze or you overorder everything. But experienced clinicians don't approach shortness of breath that way. They use a few key diagnostic forks to narrow the problem quickly. In this video, I'll show you the ScrubNotes framework for shortness of breath, so you can go from "I'm short of breath" to a focused diagnosis in just a few steps. At ScrubNotes, we approach every chief complaint the same way: safety first, look for patterns, identify key diagnostic forks. And later in the video, I'll show you one physical exam shortcut that helps you localize the problem very quickly. When a patient presents with shortness of breath, the first step is not labs, it's pattern recognition. So you want to ask, when does it occur? Is it sudden or gradual? Constant or episodic? Wheezing, chest tightness, or cough? Any triggers? Because these questions immediately start narrowing your differentials. At the same time, we always start with safety. Before anything else, rule out dangerous causes of shortness of breath. So we want to check red flags like, is there chest pain? Because that could indicate ACS or pulmonary embolism. Severe dyspnea at rest, hypoxia, cyanosis, hemoptysis, sudden onset. The goal here is simple. Don't miss something life-threatening before moving on to common causes. In this video, we'll apply this framework for a mock case of a 26-year-old female who presents with shortness of breath. Shortness of breath feels overwhelming, but clinically, most cases fall into just a few buckets. So we have obstructive causes like asthma, it could be infectious causes like pneumonia and bronchitis, cardiac causes like heart failure, could be related to anxiety, and then other bucket could include vocal cord dysfunction and GERD. I like to think of shortness of breath as a risk stratification problem. So my goal is to try and identify where the patient fits in the risk tiers. Is it emergent? Is it concerning? Or are they stable? I've provided some criteria here for you, but let's see how focused history questions can help us narrow that down and identify which tier the patient fits in. So here's some focused history questions we can ask to help narrow down our differential list quickly. To start, you could ask, when do you feel short of breath? If it's with exertion, I'd be thinking cardiopulmonary cause. At rest or sudden onset, I'm more concerned about a PE or severe asthma. At night, or lying down, that could be indicative of congestive heart failure or asthma. Next, you'd want to ask, how does it start? If it's sudden, PE, pneumothorax. If it was gradual onset, asthma, COPD, congestive heart failure are all causes. If it was after an illness, you'd be thinking infection or asthma exacerbation. Then I'd want to ask for the patient to tell me more about their cough. So if it's a dry cough, that's likely asthma. If it's a productive cough, it's more indicative of infection. And at nighttime, that could be asthma or congestive heart failure. Then you want to make sure that you ask about any associated symptoms. So if there's wheezing, that's an airway obstruction. If there's fever, productive cough, more likely pneumonia. Pleuritic chest pain is indicative of PE. And then, of course, we want to ask about any concerning symptoms like severe dyspnea at rest, if there's any chest pain, syncope, hemoptysis. So if it's yes to any of those, you probably want to refer for an urgent eval. By asking focused history questions, this is exactly how we narrow differentials across every chief complaint in this video series. So remember, patterns first, don't go chasing labs first. Shortness of breath is really a problem of oxygen delivery, so we can localize it using patterns. Here's a little algorithm I've put together to help us do that. So first we want to ask about any red flags. So is there acute distress with signs of hypoxia, severe working of breath, and silent chest? If yes, then we'd probably want to send for an ED eval. Next, we can use pattern recognition to help us identify where is the problem. So we have the pattern of parenchyma, which could present with crackles on our lung exam, and that would be indicative of pneumonia. If there was a perfusion problem, that's likely peritic, then we'd be concerned about a PE, and that's an emergent referral. If it's a pump problem, we might see signs of swelling, in which case that would be indicative of congestive heart failure. And there could be a metabolic problem, which is a more systemic presentation and might present like anemia. Lastly, if there's an airway issue and wheezing, I'd be thinking about asthma or COPD. And if that airway obstruction is reversible, then that's more likely leaning towards asthma than COPD. And as a helpful reminder and study aid, if you're suspecting pneumonia for a patient, don't forget the CURB 65 to help you identify severity. So confusion, uremia with a BUN score greater than 20, if there's a respiratory rate greater than or equal to 30, if blood pressure in systolic is 90 or 60, less than 60 in diastolic, and if they're over the age 65, then you would score that accordingly, and that helps you guide whether you need an outpatient care or considering admission. So basically we're asking, is this a narrow tube problem, a fluid problem, or a circulation problem? And that single framework dramatically simplifies shortness of breath. Okay, so let's see what our case presentation is for today. We have a 26-year-old female who presents with intermittent shortness of breath and chest tightness for the last 6 months. Symptoms worsen with exercise and exposure to cold air. She has occasional nighttime coughing, but reports no fever, sputum production, or chest pain. She denies a history of smoking, and she has a history of eczema. Let's revisit our 26-year-old case of shortness of breath. So we had episodic symptoms with triggers and nighttime cough. That's leading strongly towards an airway signal. So I think I'm going to go with asthma as my working diagnosis, but I'm going to also keep in mind exercise-induced bronchospasm and bronchitis. So this is where things start to become very efficient. Since we've asked focused history questions, that allows us to have targeted physical exams. So we can ask, is this a fluid problem, a narrow tube problem, or a pleural problem? Let's take a look at our physical exams table here. So if we're suspecting an airway issue like COPD or asthma, we're probably going to hear wheezing, there might be episodic shortness of breath, and some known triggers. So you definitely want to do a lung exam and focus on the expiratory phase assessment as well. So for our 26-year-old case, let's assume there's diffuse expiratory wheeze, prolonged expiratory phase. For suspected pneumonia, you'd probably hear crackles, there'd probably be fever, and a productive cough is likely. So again, you'd want to have a lung exam and auscultate and percuss especially. I'd also perform agophony as a special exam. And for our patient, let's assume there's no crackles, no focal, and agophony is negative. If there's a perfusion issue, like a PE, there'd be pleuritic chest pain and probably some tachycardia. So for exams, you'd want to check vitals, especially heart rate and O2 saturation. And then I'd want to do a lung and heart exam as well. So for our patient, let's assume that they have normal O2 and there's no focal issues. If there's a pump or heart issue, like in congestive heart failure, you'd probably see some edema and orthopnea. So again, be sure to perform a heart exam, a lung exam, and I'd also want to check for peripheral edema in the lower legs. So for our patient, let's assume that's within normal limits and no edema. And lastly, you could consider an upper airway obstruction. So you'd hear stridor, there'd be acute distress. So again, a heart and lung exam here are your go-tos. And for our patient, let's assume there's no stridor. You can often localize the diagnosis just by listening to lung sounds. So when you hear something abnormal, you could ask, is this musical? If yes, I'd think of a wheeze. If no, I'd want to ask, is there popping? If yes, that's indicative of crackles. Is it a grating sound? That's more likely a pleuritic rub. And is it loud over the neck? Then that would be more indicative of stridor. I provide this little table here for you as a quick OSCE reference. So for our case, if we heard diffuse expiratory wheezing, that's pretty classic for asthma. Okay, so let's bring all of this together into an assessment for our patient. We have a 26-year-old female who presents with a 6-month history of intermittent shortness of breath and chest tightness. She reports that her symptoms are episodic and worse with exercise or exposure to cold air. It's associated with nighttime coughing. She denies fever, sputum production, chest pain, or a history of smoking. She does have a history of eczema. Physical exams today are notable for diffuse expiratory wheezing and a prolonged expiratory phase, with otherwise normal vital signs and no focal lung findings, edema, or signs of cardiac involvement. The episodic nature of her symptoms, identifiable triggers, nocturnal symptoms, and atopic history are most consistent with mild persistent asthma. Alternative causes of dyspnea include pneumonia, pulmonary embolism, and heart failure, but these are less likely given the absence of supporting history and exam findings. Before we finish, here are 3 common mistakes students make with a shortness of breath chief complaint. The first one is skipping severity. They don't ask about hypoxia, work of breathing, or silent chest. This can miss important respiratory distress or severe asthma diagnosis. Number 2 is ignoring physiology. So don't jump to pneumonia or asthma without asking if there's wheeze, crackles, or a normal exam. Your real discriminators here are wheezing, crackles, and clear lung sounds. Number 3, missing key pattern clues. So listing the diagnoses before asking about triggers, if there's any nighttime symptoms, whether it's episodic versus constant. Because remember, pattern is the strongest discriminator for shortness of breath. So let's review our shortness of breath framework. Remember, safety first. We want to make sure we rule out any severe asthma, PEs, or pneumonia. We can use that classic pattern of episodic shortness of breath plus wheezing plus triggers and nighttime symptoms to help us remember that asthma is a likely cause. And then we want to look for key diagnostic forks. So if there's wheezing, I'd be thinking about airway issues like asthma or COPD. Crackles, I'd be thinking more pneumonia or congestive heart failure. If there's pleuritic chest pain, I'm concerned more for a PE. And if there's orthopnea, that's a good indication of congestive heart failure. If you want to get faster at clinical reasoning, not just for shortness of breath, but for any chief complaint, I break down the same framework across the entire ScrubNotes Chief Complaint Series. So if this helped you, go ahead and check out the rest of the series, and let me know in the comments what chief complaint you'd like to tackle next.